Clostridioides difficile. Clostridioides difficile, formerly known as Clostridium difficile, is a gram-positive spore-forming anaerobic bacillus that causes antibiotic-associated diarrhea and colitis. It arises due to disruption of normal intestinal flora, allowing C. difficile to proliferate and release toxins, primarily toxin A and B, resulting in intestinal inflammation and epithelial damage. Peak incidence. Most common in individuals aged over 65 years old. Risk is also increased in hospitalized patients, recent antibiotic users, and immunocompromised individuals. Pathophysiology. Antibiotic use, especially broad-spectrum agents such as clindamycin, cephalosporins, fluoroquinolones, and penicillins, disrupt the normal gut microbiota. This allows overgrowth of C. difficile and production of toxins A and B, which lead to colonic mucosal damage, inflammation, and diarrhea. C. difficile spores are highly resistant to standard disinfectants and can persist in their environment, facilitating transmission. Symptoms: diarrhea, typically watery and frequent, at least 3 loose stools in 24 hours, abdominal pain or cramping, fever, nausea, loss of appetite, malaise or generalized fatigue. Signs: abdominal tenderness, particularly in the lower quadrants. Signs of dehydration, tachycardia, hypotension, and dry mucous membranes. Severe disease can show toxic megacolon, complete ileus, and peritonitis or abdominal rigidity. Diagnosis: stool testing for C. difficile toxin is required for confirmation. Only test patients with unexplained diarrhea of at least 3 loose stools in 24 hours. Blood tests: raised white cell count, elevated CRP, and possibly acute kidney injury may be present in severe disease. Severity assessment, UKHSA and Public Health England criteria. Mild, normal white cell count, less than 3 stools per day. Moderate, white cell count less than 15, 3 to 5 loose stools per day. Severe, white cell count over 15, temperature over 38.5, serum creatinine greater than 50% above baseline, and clinical or radiological evidence of severe colitis. Life-threatening, if hypotension, complete ileus, toxic megacolon, and CT evidence of severe disease. Complications: severe dehydration, electrolyte abnormalities, for example hypokalemia, toxic megacolon, bowel perforation, pseudomembranous colitis, sepsis and multi-organ failure, and death, particularly in elderly or frail patients. Management: supportive measures, fluid resuscitation, electrolyte replacement, and stop the inciting antibiotic if possible. Medical treatment: first episode, first line, oral vancomycin 125 mg 4 times a day for 10 days. Alternative, oral fidaxomicin 200 mg twice a day for 10 days. In severe infection, consider oral vancomycin plus or minus IV metronidazole 500 mg TDS. Recurrent C. diff infection. Within 12 weeks, oral fidaxomicin. After 12 weeks, vancomycin or fidaxomicin. Multiple recurrences, at least 2 episodes. Consider fecal microbiota transplant, FMT. Life-threatening C. diff infection. Oral vancomycin 500 mg QDS. IV metronidazole 500 mg TDS. Surgical review for colectomy or diverting loop ileostomy may be indicated, and ICU level care if needed. Other therapies: bezlotoxumab, a monoclonal antibody targeting toxin B. This may reduce recurrence in high-risk patients, but is not currently cost-effective for routine NHS use. Prevention: hand hygiene. Use soap and water. Alcohol gel is ineffective against spores. Infection control: single room isolation, personal protective equipment PPE, gloves and apron, and environmental cleaning using chlorine-based disinfectants. Antimicrobial stewardship: avoid unnecessary antibiotic use and use narrow-spectrum agents where appropriate. That was the full video, and there's hundreds more like it waiting for you at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today